reporting back on the first panel that happened yesterday on successful outreach strategies to empower communities. There was this amazing group of panelists and a moderator, Sanisha Dale, Glenn Steverson, Jessica Sales, Catherine, the same thing as Robin Macapagal, but Macapagal. Did I get it that time? Excellent, Macapagal. Got to say it again to reinforce. And Jim Pickett. And we got to meet with them yesterday afternoon with a large group of people. And what we talked about was really kind of capturing the cross-cutting strategies that were called out in multiple places. These are the same 4 buckets that Robin had drawn out in her introduction yesterday. Really community-centered approaches, innovative outreach and engagement, scalability and sustainability, and empowerment and agency. And I'm going to talk briefly about the first 2, and then Robin's going to talk about the last 2. And so some of the newer pieces that showed up in the broader conversation there, in terms of the community-centered approach, we certainly heard the call out from Cherie Schwartz's presentation of equitable compensation for community CHWs, community members, community consultants at all levels. Another really interesting piece that came out in the discussion was this piece of inverting the expert hierarchy and recognizing the value and importance of community expertise and knowledge, which is really standing on its head the way the usual system works. And pay attention to that. And they were doing it in those projects in terms of calling out and really honoring the expertise of the people on the front lines and the people in the streets. The next bucket that we were using was innovative outreach and engagement. Funded teen research assistance, hooray. Teen-guided social marketing, bundled strategies, local venues, and certainly that interactive systems analysis and a community organizing approach. That mobilization, that listening ear. I certainly love, my husband was a community organizer, and he used to use that picture of, you got your mouth shut and your ears open. And that community organizing approach is so important in really creating space for innovative outreach and engagement. I'll turn it over to Robin.
Thank you. Did I do that? So sorry. It's not. Okay, in my 3 minutes here. So taking the scalability and sustainability, a recurring theme to consider is how these interventions, of course, can be scaled and sustained over time. And certainly considerations for funding and engaging with policymakers, which is beautiful that we have our policymakers here, our funders here, and all of us who are trying to be the boots on the ground in various ways, and ensuring that the interventions remain culturally relevant and responsive to community needs as they continue to expand to be responsive in the moment so that they can be translated. And then empowerment and agency. So not only to prevent HIV, but also to empower the individuals and communities in ways that is from the ground up. And so, of course, this includes education and training and the active participation so that it's agency and self-agency, and so advocacy and self-advocacy. And so that they can all be part of this pipeline and be one in which it's diverse and representative of the community in which we are looking to support, and as well as having our students and scholars. And so there was a wonderful discussion around how our scholars and those who are accepted into the programs really needing to have those who are representative of our different minority groups and those that need to be part of this. And as you can see at the bottom, the challenges and barriers to implementation, of course, were discussed. But I think that one of the really lovely things about this are really moving toward the ability to strategize and have those specific mechanisms and strategies and methods aligned with the challenges and barriers. And so just thinking broadly, these presentations and the discussion, the follow-up focus group discussion, collectively really talked about impactful, community-centered strategies aimed at enhancing the work and by leveraging local partnerships, engaging directly with our communities, and employing these innovative outreach methods. These direct initiatives may increase awareness and accessibility and uptake. And so I would, with this next slide, let's see if I can go. What we did during the meeting was have a little QR code for those who were part of our group there to be able to share their own strategies. So we have an invitation for everyone here to take this QR code and share with us what your successful strategies are so that we can really have a collective community engaged building of each other's strategies and a collection of that. Right before we walked up here, I sent an email to all of those who were shared their email and name at our group yesterday so that we have already started sort of this group to be part of talking about these strategies. So please, if you are interested also in sort of sharing back, we welcome that. So thank you.
Hello, everyone. This was such a wonderful 2 days with you all, and thank you so much for the active contributions to this specific panel. For those of you who came, you might remember that this panel presented on lowering barriers to care through community engagement, and then we had a breakout discussion to continue exploring some of these issues. You can see the presenters here. We had 3 presentations, the first one by Dr. Kanamori and Dr. Fallon, around finishing HIV, which was a project for providing PrEP for MSM community and in Florida and in the Miami area. And it was talking about various types of ways that community was engaged and thought about. We also had a presentation by Dr. Matthews and Deandra Tuyishime talking about PrEP and screening in the context of rural communities in Alabama and even mobile units and how they could be used. And finally, Jeanette Webb talked about working with criminally involved, justice-involved communities and how you can bring health promotion broadly and specific to PrEP and other HIV-related services to them. All 3 of them brought out this idea, what we finished with yesterday here about this time, that the idea of creating something and hoping the community will come to us is foolish, and that we have to actually come to them, understand their needs, preferences, priorities, and resources, and co-create solutions with them. And I think that most of the discussion centered around this idea, how can we do this well? How can we engage considering the contextual reality of these communities, which is that they have competing needs, which is that they don't necessarily have the resources that we expect to have to establish new services, and that often when we come in with an idea that doesn't align with their current urgencies. And so thinking about these issues, our smaller group identified a number of themes around, key barriers, challenges, and potential strategies or next steps. I wanted to highlight a few of them. You can, of course, read all of them here. One of the things that came up, and this is where, again, we finished here, was money. And money in different ways. And, it might not sound really very inspirational, but the truth is that often this comes down to resources, whether we are successful, whether we are engaging the right way. And the different aspects of money was basically budgets. How do we create budgets in collaboration with our communities for research plans? How do we engage them in that process and make sure that they receive an appropriate, equitable portion of our funding so that they can do the work they need to do? And some of the expansions that happened during our session was that perhaps you need to create modular budgets, budgets that will adjust to the community's services. So you cannot just fix them in and say, this is the amount you get. If you are going to increase the service needs, there has to be a way to easily adjust to that. So there was a recommendation from one of our community partners who has background in business and development of thinking about creating these modular budgets that can absorb new services in a way that you move to the next tier. That I thought was brilliant, and that can be considered both by the community partner and the research partner. The other aspect of budget was actually something that was mentioned by one of our participants who couldn't get in time-wise, but I thought it was important, is compensation. What is equitable compensation for community partners for the work? How does that change across different geographical areas, considering the cost of living? How do we adjust that over time as inflation is happening? How do we separate that from reimbursement for their own costs? So we don't mix together compensation for their time with travel time or money that they need to pay for childcare or leave from work. So finding that way and getting guidance broadly from funders across different, kind of units and thinking about geographical areas would be critical. So that was kind of a theme. Another one was definitely sustainment. How do we design with sustainment in mind? How do we sustain our partnerships? How do we sustain the work that is being done in a given project? And I think that, there were more questions left than solutions, but some of the thoughts were to think about where the puck is going. So as you are working with your communities, ask them, what is the next thing for you? That might be a different type of approach to HIV prevention that they want to explore, and there were some examples of moving from one type of research project to the next one that now moves to this new direction. Also thinking about, as we are setting up our services, to have their input and buy-in so that these services are designed with them in mind. I only have a minute left, so I'm going to highlight a couple of more things. One was it seems like it's a very soft thing and it's hard to measure, but trust. Everything came down to trust. Does the community trust us? Do we take the time to listen to them? I love Debbie's comment. Actually, I would like to meet her husband now because she mentioned multiple comments from community organizing of how to use these ideas. The listening. Coming to them that you want them to do something is perhaps not the best entry, and coming to them to ask what they need and then come up with a solution and help them facilitate that work and empower them, I think is the key approach that we discussed. And then one other thing that I will highlight, and I'm sure that those of you who were there thinking that I missed out things, please feel free to come up later. But one other thing that I thought was important is linking services. So as you are working on one type of prevention approach, it is okay for you to take advantage of other things that are important to the community and embed it within that. So you are serving their needs, and then also you are bringing in the things that seem to be important from a public health perspective. Thank you again for the opportunity, and thank you for everyone for the contributions.
Okay, we're strategy panel 3, partnering with public health departments across the care continuum. No slides and horrible handwriting, so hopefully I'll be able to tease apart what I wrote down here. Thanks for the great contributions from the group. We had a discussion that went really in two different directions. We talked largely about how do we create or foster partnerships between public health departments and academic institutions, which I'll get to because there's a lot of complexity there. But the other area which we spoke about was on how do we enhance the transferability, some might say generalizability of results, like we had 3 presentations today. How do we take the results from the findings from those studies and bring them into new settings? And an idea came up that, well, first, we should be having some sort of logic model, and probably an implementation research logic model, which clearly articulates what are the determinants that the strategies are addressing, how do those strategies layer on top of those determinants, what's the mechanism for change, and then the outcomes that we expect to see, and hopefully can verify that through the research itself. And that will help to then see in other settings where there are common determinants that, well, maybe this is the right kind of strategy for where we're working. We also had a discussion around the sustainment of conditional cash transfers, contingency management. It's one of the big questions in the field where research largely goes on for, say, a year, and then when the incentives are pulled out, the results they also fade. And so there's a question of, well, can we be a little more explicit in talking about conditional cash transfers? Not keep it on the down low, but make it something which is really discussed and brought to the forefront, because if it's an effective strategy, then it's something which may need to perpetuate. Maybe it's not something you can do for 12 months and then expect there to be continued effects of the contingency management as people's lives are very complicated and will continue beyond the 12 months of receiving that support. Now, speaking around the academic public health partnerships, we talked a lot about the burnout that health department staff are feeling and high rotations, a lot of vacancies that take a long time to fill, and so that turnover's really difficult for public health departments, and it is a challenge for creating partnerships with academic institutions. There's no magic bullet panacea here, but a couple of ideas surfaced. One is that an academic public health partnership can actually be an incentive, a perk for staff and health departments. It gives them an opportunity to network with others. It gives them an opportunity to develop new skills if done appropriately. A new way to see work, the work that's being done, a new perspective, and oftentimes in-kind support like attendance at conferences that can go along with those partnerships. There's different models that are out there. In Seattle, the Public Health Seattle-King County has joint appointments with the University of Washington, and that's one way to help deal with leadership vacuums and can create potentially more long-term sustainable positions or staff at health departments, and does bring potentially some of the perspective as academia into public health leadership. And then another way to try and improve or address some of the staffing issues is to integrate the training pipeline into public health departments. So in some areas you have people who are getting an MPH or getting another degree in public health who are doing their research or practica at public health departments. So that can really kill two birds with one stone. It can provide health departments with warm bodies that may be needed, who are eager to hopefully engage in long-term into public health work. And it also can provide potentially people who will then go into a long-term public health career at a health department. So it's one thing that we could work on integrating. Very quickly, we talked we also talked about the need to really be developing the careers of people who are working at health departments. Natalie Kramer from NASDAD spoke about the Minority Leadership Program, which is in its 10th cohort, which is a mid-career development program for BIPOC staff, and really is a pathway to progression in people's career, and also created a network across different health departments for folks to get support and during hard times like COVID, or if they're facing burnout, and really can focus on their own wellness. Some best practices for fostering academic public health partnerships. One is really focus on the bidirectionality. There can be synergies that emerge from these relationships. You have health departments with needs. They have questions, analytic questions that maybe they have and want support with answering. Well, you could have students and faculty and staff from academic institutions help respond to those questions. Really give health departments what they want. Be self-aware and sensitive to others. Don't just come in and ask for a letter of support, but realize this is a relationship that you need to foster over time. And that will create new opportunities going forward. And we came up with 2 research questions that we thought would be really interesting. One is, having unrestricted funding as an implementation strategy, and to see if that really improves the delivery of evidence-based interventions over time. Oftentimes we have things like a status neutral approach, not really working with CDC and HRSA funding. And second is a de-implementation research topic. What can we stop doing at a health department level that's ineffective and takes time, and then we can reprogram the time of staff to do other things. And 7 seconds left. Thank you all. If I misrepresented anything, sorry.